Today I'm going to talk a little bit about value, and I just want to mention that I have no disclosures or no conflicts of interest that I think should interfere with what I have to say, but I really would like to acknowledge the American College of Physicians, and particularly Dr. Steven Weinberger, who's our current CEO, who has championed our effort, or the college's effort, on the high-value, cost-conscious care, which I'm going to speak about, and the other members of the college who've put together some of the material that I'll be talking about today. Now, as Dr. Laskovsky mentioned so clearly, we as physicians and other healthcare professionals really want to do good things for our patients. But when we start to measure what we're actually doing, we sometimes find out we're not doing as well as we thought we were. But even that has helped us to make changes. And so in the last decade, there has been a lot of efforts that have started to improve quality and safety and issues around getting people the care they deserve. A couple of efforts I might mention in our own region, the cardiothoracic team, and I didn't even know about Dr. Gardner's association, but I want to tell you that the Northern New England Cardiothoracic Collaborative got together a number of years ago, started publishing what they were doing, measuring what they were doing, and made enormous improvements, as well at the same time as taking great risks of putting their information in the public sphere. And I know in our own clinic, when we started to look at blood pressure control, I'm a nephrologist, as mentioned, and we think we're the best at managing blood pressure. And when we looked at how well our patients were actually doing, only about 30% of them were at the goal we thought they were at. But by just measuring things and letting everybody know where we were, we improved to about 60% at goal, within a few months. So measuring and thinking about things is something that we've all started to do, but we have to continue to do. And so I'm looking forward to hearing about more of this later today. But what I want to talk about is the fact that although we're making some improvement in terms of quality and safety, the big cloud looming over us all is the costs of healthcare. And so as we go into our next decade of this new century, we have to start thinking about cost. A kind of nasty word when we're thinking about doing good. But let me try and explain to you how I think we can do both. Now, why costs? I'm not sure many of you have seen pictures like this before. The rising costs of healthcare in the United States are simply unsustainable. In 1960, the cost of healthcare was about $330 billion. It's currently $2.7 trillion. By 2015, will be about $4 trillion. And you can see the rate of rise. As a percent of GDP, 17.6% and going on up. This means that there is no money available for all the other things that we need to do. If we look at who is spending that money, we know, we hear a lot about how the government is very concerned, both local, state, and the federal government is extremely concerned about healthcare costs. You can see here that Medicare and Medicaid, which together account for about 30% of government spending, federal government spending, that's really a considerable proportion, but the rate of rise from here going up is moving that even further. And this is now as a percent still of gross domestic product. But you can see that while government is spending a lot on healthcare, there's all this other healthcare. This isn't government, this is us. This is everyone, or we're government too, but this is everyone. This is private money. This is out-of-pocket costs. This is money, disposable income that people need to run their lives. And so healthcare costs are not just a problem that the government has to face, but that we all are responsible for, or we all have to face, and therefore should be responsible for. if we look at what's happening in the rest of the world, and it's never good to compare yourself with others, except to sort of look around and see if you can learn something, we can notice that here's the United States here and all the other countries, that our healthcare percent of GDP is about twice that of most of the other industrialized countries. Sadly, our outcomes are not as good. We're 12th behind. We're 12th behind another set of countries in infant mortality and life expectancy. And you'll also note that you also know that we don't cover all the people in the country. So although we spend a lot, we're not really getting the outcomes that we all desire. And again, you'll note here that government spending in the blue bars is not that different in terms of percent of GDP to other countries, but the private spending is much greater. So again, this is a problem we all have to be very concerned about. Now, when we look at healthcare spending, it's instructive for us to sort of see the fact that although we are rising at a greater rate here, back here in 1970, 40 years ago, compared with other countries, we're all about the same in terms of per capita spending, but that somehow spending here has taken off. It doesn't mean it isn't going up in other countries, and cost is a problem all over the world. This is a global issue, and as I've had the good fortune to speak with leaders of healthcare systems in other countries, especially during this past year, everybody is saying the same thing. The rising costs are unsustainable. So we're all in this together, and we're all going to have to get solutions together. Now, if we're going to look at what to do, we have to look at where the problems are. And so what are the cost drivers in the US healthcare economy? Technology. Now, technology is a wonderful thing. It's brought us hip replacements, knee replacements, made people's lives better, kept people alive with cardiothoracic surgery and all kinds of other wonderful innovations, better medications. Goodness, we have thousands of medications now compared with even 1970. So things that really make people's lives better. But one of the problems is that we don't have any coordinated policy on health technology assessment. So even things that suddenly appear in our system which have no or little value are adopted in the same way as things that have high value. And when we look at what's going on, we have a lot more of these technological devices like MRIs and CT scanners, which are expensive, although extremely useful, and we have more than any other country except Japan. Now, it's interesting, though, that Japan's costs are not quite as high because there's not quite the same incentive to use these in Japan, and the cost of all the tests is much lower. Chronic disease and aging is definitely another healthcare cost driver. And those of us who belong to the baby boom generation realize that we are going to be contributing to this, as most of the healthcare costs that people have happen in the latter part of their life and often in their very last years. But if we look at the little graph here that shows our percent of GDP here, and this is 2010 and 2080 up here, you can see that there is this bubble of aging that is going to increase the expenditures here. But look at these excess healthcare costs. They are taking off in a way that is independent of just the aging and chronic disease burden that we are facing. Excessive pricing is a real issue. There was a recent paper in Health Affairs which say that physician services are actually higher here than many other parts of the world. That per capita expenditure for drugs, we use more prescription drugs than any other country. Not just more, but a lot more. 60% of the population use at least one prescription drug, and 25% use more than 4. And that's compared with countries like Switzerland, who also have all these things available, where less than 1 in 10 people use more than 4 prescription drugs. This is not to say these are not good things, but we have to think about, are we using everything as effectively as we should? We have fewer primary care services, and we know that with better primary care, costs are lower. Again, a picture that's a little bit hard for you to see here. I'll point out this is the primary care score against the per capita spending. You can see here's the US way out here, higher per capita spending, lower primary care score when you add it up in some way, and the other countries. And we know that people who get more primary care services tend to get more preventive services, and so we may be able to get services to people at lower cost, get to them earlier so that they don't end up with the high-priced services that may be contributing to not only driving healthcare costs. Liability is a problem. We do have a high cost of medical liability, and certainly some areas of tort reform could save maybe $62 billion. But this is actually the liability is less than 3% of overall healthcare expenditures, so it's important, but it's not the driving force all alone. It's something we need to address, but can't use as merely an excuse for what our problem is. And then there's this big elephant that I'm going to talk a little bit more about, overuse and misuse of both treatments and testing that may account for as much as $700 billion, almost a third of the healthcare expenditures, both public and private. So what can we do about this, and who should do it? We are physicians, so why doctors? Well, we order the tests, we write the prescriptions, we do the procedures, and although we may not be, our payment for a lot of these things may not be the driving cost, the fact that we control all these procedures does have an influence on the cost, maybe as much as 80%, that we have some influence over, which means we are responsible. We are responsible for making sure that what we prescribe is safe and effective. And we're thinking about the cost. And as Atul Gawande, who always seems to be able to say things very clearly, and many of us wish we had this same skill, that healthcare costs ultimately arise from the accumulation of individual decisions doctors make about which services and treatments to write an order for. Now, the second reason doctors and other healthcare professionals, because we're all healthcare professionals and we are all finally working together in teams and seeing ourselves as a united group in this effort, the reason we have to be doing something about it is that despite everything bad that's sometimes said about us, the public really trusts us to recommend changes that reduce costs and trusts us more at the moment than government, insurers, or payers. And then we have our own intrinsic responsibility, medical professionalism. The American College of Physicians put out the 6th edition of the Ethics Manual in January this year. It is published and available to all in the Annals of Internal Medicine. And there is a paragraph in it which brought a lot of publicity, including some NPR interviews and comments from a lot of other organizations. And this paragraph read here that we have a responsibility to practice effective and efficient healthcare and to use healthcare resources responsibly. That parsimonious care that utilizes the most efficient means to effectively diagnose a condition and treat a patient respects the need to use resources wisely and help ensure that those resources are equitably available. Parsimonious was grabbed on. You look it up in Merriam-Webster or any other dictionary, and it says frugal to the point of stinginess. But on the other hand, there are other definitions that say it's doing just the right amount and not excessive. and links it to the idea of Occam's razor, which many of us know as a major principle in making diagnoses in healthcare. So it's like everything, it's which definition you choose to listen to. But we think parsimonious is a good word, and interestingly enough, it was put in our ethics manual, not in the new edition, but back in the 1990s, I think, by Ed Pellegrino, who was a wonderful ethicist when this was written. So we are quite proud of it and think it actually says the right thing. And there was another document that also came out relatively recently called Medical Professionalism in the New Millennium, a Physician Charter, which was published 10 years ago. We're coming up on our 10th anniversary of this by the American Board of Internal Medicine Foundation, the American College of Physicians Foundation, and the European Federation of Internal Medicine. And this part of the Physician's Charter again states our obligation to meet the needs of individual patients, to provide health care that's based on wise and cost-effective management and limited clinical resources. None of these ideas that we talk about are ever new, but we have to keep talking about them because we're not getting to the answers yet. And that our responsibility is the appropriate allocation of resources, and that we should be scrupulous in avoiding superfluous tests and procedures. Because this not only exposes patients to harm and expense, but diminishes resources available to others. Now, what are the particular physician-driven sources of excessive healthcare costs where we might be able to make a change? I mean, healthcare is costly, and good healthcare is quite costly, and we all want good healthcare, and that's in particular patients do and are prepared to pay. But we don't need to do things that are unnecessary. There are definitely preventable and avoidable hospital admissions and readmissions, and people are working on that. Inappropriate non-beneficial treatment, but I'm going to focus a little bit on where we thought the first place to start would be, and that is on the low-hanging fruit, the inappropriate diagnostic testing that may account of this $7 billion pie here, about $210 billion, a significant amount that we could do something about. But how? Oh, just to remind you that most of the, if we look at, this is now cumulative percentage increase, okay, this is the actual number of things that have happened per person to Medicare beneficiaries from 2000 to 2009. So this isn't cost, this is just number. And you can see that if we look at these top two curves here, imaging and tests, they are rising at a much greater rate than things like E&M services, going to see the doctor and having a talk, or even major procedures, the things that happen when people have acute events. And that there is this huge discrepancy here, and that this is something that we might need to do something about. So why are tests overused or misused? Well, there's a number of reasons, and this is not even a complete list. But lack of guidance or knowledge. We don't have enough guidelines, and when we do, they're not always followed. And guidelines don't always refer to all the people we treat. Guidelines tend to be come from fairly narrow studies and sometimes don't incorporate what we need to do for individual patients. But they're still important, and we should be using them most of the time. We don't have enough comparative effectiveness research, which tells us whether one form of treatment is better than another. This perfect example, again, that Dr. Gardner mentioned this morning, where the cardiothoracic bypass, where the bypass surgery is better than putting stents in for long-term outcomes for patients. We need to know that, and patients need to know it too. But that requires research. There's always this myth that the reason we do so many things are because patients demand it. And indeed, patients are being much more involved in their care, and they do have demands, and so they should. And when you think about the fact that they receive information about 16 hours a year from the media and from advertising compared to the 4 hours a year they get from talking to their doctors, you can see that maybe that's why they do come in with information that they want to find out about. But it's our job not to blame them for having maybe some misguided ideas, but to be able to educate and persuade them. That's what we have to do. The fear of malpractice I mentioned is true and is a driving force. Habit is a problem. I'm a nephrologist. We like to look at creatinines and electrolytes. But do we need to do it every day when people are in the hospital? We have to sort of start to think about what are we doing just because we're used to doing it. And then, unfortunately, there is personal gain. Some of the personal gain is not malignant in the sense that people are still doing what they think is best. But the healthcare funding system, the way people are paid, encourages sometimes overuse of certain things because the incentives to do tests are often greater than the incentives to spend time talking to someone. And then, of course, there is fraud and abuse, which we hear about, and there are people who absolutely do more than they have to do for personal profit. Again, Tul Gawande puts it quite well, that, and maybe I think a little extreme, but we need to hear these things, that the battle for the soul of American medicine is over, whether the doctor is set up to meet the needs of the patient first and foremost, or to maximize revenue. We have to ensure that our systems do not encourage this, as well as maintain our sense of professionalism. Now, the American College of Physicians was very interested in this idea that we have to do something about cost, and in January of 2011 launched the High Value Cost Conscious Care Initiative, came out with a position statement that recognized the fact that we can't do this alone. We have to be partnering with patients to make the right choices that are right for them, and that we have to be working with society because allocations decisions have to be informed by evidence and the value of different interventions. We have to link them to societal values. We have to think about the moral, ethical, cultural, and professional standards that we all want to see maintained, and we need the public to think about this if we're going to be able to make any changes. So the initiative was first to work with physicians about the appropriate use of care, particularly diagnostic testing, because this is something we might be able to do something about, and we needed data to do that. We wanted to bring people together, and then we wanted to educate. That's what we as doctors do best, and certainly what we as the American College of Physicians do best. We're very good at education. But we can't just educate practicing clinicians. We have to look at trainees, and we have to help patients. So the first paper that came out, this was back in February the 1st, 2011, was described the fact that we need to look at not just cost, but benefits, harms, and costs whenever we do any kind of testing. And that the challenge is, how can we slow the rate of cost by preserving high value? And that is the thing that we're going to be talking about more today. Just a short break, a few definitions. I think you all heard this already. You know, the idea of value is that it is benefit. It's a function of benefit, cost, and harm. I don't like these equations because obviously they don't make sense, but just think of it as a function of these three things. That when we talk about efficacy, we're often talking about what works under ideal circumstances. Many randomized controlled trials on which we base our clinical decisions are actually only carried out in people who are very homogeneous. They have a single disease, they maybe fit in a small age group, and therefore are not generalizable to all the patients we see in our clinic. So we have to be able to do more things that will perhaps evaluate effectiveness. That is, how do interventions work in typical real-life situations? And that's why comparative effectiveness, which looks at different treatments and true effectiveness, are things that we need more information about. And then there's cost effectiveness, which compares benefit with the costs of two strategies. And this is really more appropriate for population studies, as we'll hear more about also today. Now, when we're talking about value, we have to remember, or benefit, cost, and value, we have to remember that all things that are low cost are not necessarily high value. And all things that are high cost are not necessarily not good value. So we have to try to pick out the right things here. Things like HIV screening is relatively low cost in a population with a high prevalence and very, very high benefit. Whereas, and things like not doing an MRI when somebody walks in with their first episode of low back pain, not linked to any other condition or history or major problem, that this is very high cost and very low benefit, and these are the things we shouldn't be doing. But then there are the other things, treatment, which can be high value depending on the benefits and harms. Sometimes some other issues that can be both low value or high value depending on the benefits and harms. Now, as I mentioned, the first paper the ACP put out was this global idea of what you'll be looking at, and the second paper that came out in the same edition of the Annals was looking at diagnostic testing for low back pain, what I just mentioned. And in this paper, people looked at all the studies, the meta-analyses, the control trials, everything that had been looked at to evaluate if a person who walks into an emergency room or a physician's office with low back pain and gets some kind of imaging test, whether that would be of benefit to them. And it turned out there was no benefit at all, not for the pain resolution, not for function, not for quality of life, not for people's understanding of the problem or overall benefit. No benefit from doing this in people who didn't have some other indication of serious underlying disease. And there was also documented harms, low-level irradiation, clinically irrelevant findings, which led to other costs, all these false positives and other costs which cause a lot of worry to people, as well as costs to them individually and to the society as a whole. And then they looked at why did people do it, and the same things came out. Some financial incentives, some defensive medicine, some that it was easier to just do the test than take the time to explain what was going on, and the old idea that patients want it. That again is something that we are partly responsible for. We have to help patients want things that are relevant to them. Subsequently, a year later, we have another paper that talks about the another 37 clinical situations that people got together to think about, and for which there will be more evidence presented later. And this comes into the fact that other groups are getting together to deal with this as well. The idea of all these papers and studies is that we want to encourage people to follow treatment guidelines if they are relevant to the particular patient. And as I said, probably only 20 to 50% of guidelines are actually followed. Now, we all know that there are outliers, 10%, maybe 20%, which don't fit the guidelines. But you know what? 20% followed guidelines means we're missing out on a lot of people who would. And we need to also promote research, and we need to think about our payment and delivery systems. One of the payment and delivery systems that people are working more to foster these days is the patient-centered medical home, where patients can actually have a team of people to look after them and therefore get the appropriate care from the appropriate person when needed. with a lot more whole person orientation, emphasis on quality and safety, and supported by a payment structure that recognizes value, not just volume. And this is something that we are going to change, whether we like it or not. It needs to change. We just have to build it correctly. And that's another whole topic of how do we do that. But the patient-centered medical home, which is now being adopted in many parts of the countries, has mixed results. It's early days, but there is some evidence that there is a reduction in the high-cost ED visits, fewer hospitalizations, improved staff satisfaction, and improved quality in both preventive and maintenance services, which are critical for the chronic diseases that are making up most of the care that we need to provide today. Okay. So I would like to just mention that when we're talking about this idea of high-value, cost-conscious care, that we need to get rid of one idea, and that is the idea, the misperception about rationing. Rational care is what we're talking about. And rational care is trying to avoid the overuse and misuse of care. It's not rationing. Rationing is decisions that are made about allocating scarce resources to people who could use them, that underuse of potentially appropriate care. Rational care is trying to avoid the need for rationing by avoiding overuse and misuse of care that is inappropriate. So the care that we want to talk about is both medically sound and economically sound. And should I take? So we need to talk about these issues and understand what value is and what rationing is and what rational care is not. But then we have to get out and get everybody to be on the same page. So how do we do that? Well, firstly, we as the ACP is very interested in developing educational programs and products that can be used. And the major educational product that's used for internal medicine training, for certification, is the medical knowledge and self-assessment programs, and we're developing modules that have testing components in here. And the ABIM is developing testing components that take into account people's understanding of cost and value as they are improving their knowledge about what is the best possible care to deliver. The students know this pretty well. If it's not on the exam, they're not going to bother to learn it. So we have to realize that we do have to ask questions and make sure we do know what's good, and that's important. So we are working with other organizations, the Academic Alliance of Internal Medicine and the ABIM Foundation develop some curriculum to do that. And it's very, very key that we develop curriculum, because we know that habits start early, and if we don't get at the medical students, residents, and fellows and focus on things that they are doing a lot of ordering of, then we are not going to do very well. We have to remember, as in this little cartoon here, I will read the caption for those of you at the back. I think you can see the picture. Offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. And I think that's unfortunately what we all do more often than we should. Instilling value-based care requires a lot of effort and thought. It's not just something we say, do it. We have to make sure we have the knowledge about what helps and what harms. We have to change attitudes, focus on appropriate care, not cost, focus on not doing harm. We have to deal with the culture that recognition that more is not better, and that we have to do faculty development, trainees, mimic faculty. So if we're not good role models, they certainly will forget immediately what they've been taught in medical school. And we have to realize that regulation is effective, and we have to get cost consciousness as part of our residency competency requirements. As you know, we have 6 competencies in residency training. Dr. Weinberger even wrote a position statement about thinking that maybe cost consciousness should be a 7th competency. But other than that, it certainly should be involved in the systems-based practice that we all are trying to teach. Now, what about patients? I believe patients can be our best allies. Patients are like everybody else. They're not one homogeneous group. They have views that come from one end of the spectrum to the other. And there was a paper written in JAMA just at the end of last year, 2011, by Dr. Detsky, who had done a lot of surveys. This was an editorial, and summarizing some of the surveys about what patients want and don't want. And his version was that they like timeliness. They don't like to wait. None of us do. They want kindness. They actually want hope and certainty. Sounds just like everybody wants, but unfortunately, uncertainty is part of life. They want continuity, choice, and coordination. So they really do want a personal physician or a team that they can go to who knows what's happening with them. They actually prefer getting something done, like a medication or surgery, rather than being told to change their diet and exercise. Again, not a surprise to those of us who practice medicine, but something that we still need to work with them on. And they want the best medicine and the best physicians. And sometimes they're not sure who they are, but they find out from their friends. And again, we don't have any good ways of measuring who are the best physicians anyhow, so maybe that's as good as any. So I don't hold that against them. I think we do that ourselves. But he said they're less interested in evidence, in equity, that everybody gets a fair share. They don't care so much about conflicts of interest. In other words, the doctor making money out of doing the extra test as long as it doesn't affect them. And they don't care about real costs if they don't have to bear them. Now, again, I think this is a somewhat skeptical view of patients, because I think there are many patients who actually do care about all these things. And something that I know for certain patients don't like, and that is they don't like inconvenience, they don't like discomfort, they don't like losing time from work, they don't like pain, and they certainly don't like harm. They don't like out-of-pocket costs, and the way costs are being shifted in the country, more and more costs are going directly to patients, and so they really do have skin in the game and really do not want to be paying for things that they don't feel are valuable. And they do want to be involved in shared decision-making and being informed. I have patients who come in to see me who say, oh, Dr. So-and-so wants to do this test another x-ray every week about the kidney stones, or every 6 months, and do I need that? And sometimes the answer is yes, and sometimes the answer is, well, why don't you talk to him or her about that? I was driving in this morning, and the driver was telling me about his son who had gone to a doctor with a strep throat, and the doctor took the culture and sent it off and said, well, it does look pretty bad. I think we'll put you on some broad-spectrum antibiotics. And his son said, no, he said, I don't want that until the culture comes back. I don't want you populating my body with superbugs. It turns out that his father was doing a course in microbiology and had been using his son as a way to, learn things for himself. And so he had been indoctrinated very well. So we can teach people. People can learn. No, I think that there are many instances where patients don't want things that are not good for them, and it's up to us to help them understand. So there have been a number of programs where we are partnering with patients, education through the summaries for patients in the Annals of Internal Medicine. The foundation has some tips, and then there have been publications in the lay press which talk about the fact that there are pointless things that are done that drive medical costs. And more, especially just recently, there's some wonderful collaboration with consumers groups. I might mention that the National Alliance, Physicians Alliance had a top 5 campaign asking physicians to come up with the top 5 tests that they shouldn't do back in 2011. And there was an editorial in the New England Journal of Medicine by Dr. Howard Brody back in 2010 suggesting that we ought to be doing these kind of things. And just recently, this month, the Choosing Wisely campaign, a campaign of the American Board of Internal Medicine Foundation with 9 other medical groups and collaborating with Consumer Reports, got the organizations to actually come up with the 5 things that they felt maybe not needed and that would help to reduce costs. And that we are also having a campaign just after that with Consumer Reports to help. Now, the National Physicians Alliance, this was their recommendations: the low back pain, not doing lots of screening tests, don't do EKGs if you have a low-risk person, and some other issues here. The Choosing Wisely partners included groups, as you can see, from cardiology, physicians, radiology, nephrology, and they came up with recommendations, some of which were not in their own best financial interests. So people can do the right thing. Mark Twain sort of said it, and I'm afraid I have to paraphrase a little bit, that you've got to just always concentrate on doing the right thing. Some people will appreciate it and be gratified, and the others will be astonished. But nevertheless, it's going to help. And 8 more societies will be joining this effort. And this is an effort to not only say to ourselves what we want to do, but to say it publicly and to get the information out to the public so they can learn what works and what doesn't work. The 5 things the American College of Physicians said were here, that, again, things that we felt were the top 5, but we have another 32 somewhere in our other paper. And then just recently at Internal Medicine 2012 in New Orleans last week, we launched another effort with Consumer Reports where we are making all this patient education material available through Consumer Reports on not just the images for low back pain, this is one of our first ones, but choosing the right drug or helping patients understand which medications are quite effective in terms of treating diabetes. So again, a major effort to educate patients about what's going on, and these will be also available in Spanish. So do physicians all agree with this? This was a survey back in 2011 about what physicians thought about whether healthcare is overused. And indeed, almost half thought that in their own practice, patients were receiving too much care, only 6% that they were receiving too little. And again, the same concepts that malpractice was an issue. And this is going to take some education of physicians. It is an issue, but it's not as big an issue as we think it is. Or it's not an issue that we can hide behind. We have to be aware of it, but not hide behind it. Clinical performance measures. Again, this is always a problem. If we measure things, who holds people accountable? And is that being held accountable appropriate? And we have to work with all agencies to deal with that. And inadequate time to spend with patients. I think this is something that we all realize, that we can only help patients if we have time to talk with them. So there are some good efforts out there, but there are a lot of tough challenges. End-of-life care, if we're going to try and reduce cost and give value, end-of-life care is hugely costly. The data that people spend probably 80–90% of their individual healthcare dollars in the last year or 6 months of their life. That doesn't mean we shouldn't be doing things. We just have to do things that have value and avoid the futile efforts. We have to worry about conflict of interest, defensive medicine, overpricing. And we have to worry about patients' knowledge, attitudes, beliefs, and their own responsibility for doing things that may reduce costs, reduce their burden of illness, and be true participants in shared decision-making because they are informed. But we have to help them do that. And of course, healthcare is very fragmented, our responsibility. We can always say, well, I didn't order it, the cardiologist did, but we have to get together to build our teams, our neighborhoods, and make sure that we're not overdoing things that have already been done. And we have to get the payers involved in not doing and not making demands in terms of some of this accountability, pay for performance, which hasn't been shown to work very, very well, or use it in a way that's rational and reasonable so that physicians are able to do what's in the best interest of their patients while all improving the quality of the care they provide. So in summary, I just want to say that I think that trying to get value care, avoiding harms, reducing costs, and providing the quality that all our patients want and deserve, we have to think about who's going to do it, and it really is all of our responsibility. And as physicians and the public, we have to do it. Costs and unnecessary care that's neither safe or effective is not good for anyone. The who is we as a profession, as healthcare professionals, in partnership with informed patients. We have to make judicious choices about clinically effective alternatives and avoid overuse and misuse. And to do that, we have to get more evidence and we have to educate. We have to educate what I call the 6 Ps, our physician colleagues, other healthcare professionals, the payers, the policymakers, the public, and our patients in order to get everybody on the same page. We have a long tradition. For over 2 millennia, we have had people who've told us and given us principles on how to deliver the best care for our patients. This is a statement from the Hippocratic Oath. They didn't have a lot of treatments back then, so dietary was the regimen he was focusing on. I will use those dietary regimens which will benefit my patients according to my greatest ability and judgment, and I will do no harm or injustice to them. We have to remember this. And from Mahatma Gandhi, who said that if we're going to do these things, we have to be the change we want to see. So I want to thank you for your time, and if there's time later or any time, I'm very happy to answer any questions. Thank you very much.